How many of you have a pituitary adenoma? How many of you have a Rathke's cleft cyst? So one of the things that I need to tell you is that pituitary adenomas and Rathke's cleft cysts are incredibly common as incidental findings. Well, maybe not so much the pituitary adenomas, but the Rathke's cleft cyst is a very common. How many of you see them like every week? A Rathke's cleft cyst. So they're very, very common kind of lesions. So let's begin and jump into this. We're going to talk about the difference between microadenomas and macroadenomas. We'll talk about the two major clinical syndromes for pituitary adenomas. I want to mention the workup for amenorrhea because that's the way the patients clinically present, the female patients. Male patients don't complain for some reason about having amenorrhea. We're going to talk a little bit about craniopharyngiomas, and I hope at the time to talk about chordomas, which already been mentioned once before in the course. So you need to realize that there's two primary ways that we identify Sella and suprasellar masses. Patients who are asymptomatic or patients who are symptomatic. Patients who are asymptomatic, it's an incidental finding and you have to decide what to do about it. But when the patient is symptomatic, there's two primary modes of presentation. They present because of the endocrine effects of the lesion, or they present because of signs of increased intracranial pressure or pressure on the adjacent cranial nerves, which is going to be the optic chiasm, giving you the classic pattern of having bitemporal hemianopsia. But any sellar or suprasellar lesion can also affect the cranial nerves in the cavernous sinus and give you kind of a polycranial neuropathy. When you're asked to evaluate the Sella or parasellar region, when you're doing a specialized study, people want you to tell them what you see, where is it involving the cavernous sinus, is it homogeneous or heterogeneous, can you tell them a narrow kind of differential diagnosis, if they already know the patient has a recurrent pituitary adenoma, can you help them to decide between doing a second surgery or doing radiation. How many of you use a mnemonic like SATCHMO? Anybody here use that mnemonic SATCHMO for Sella? And no one with a working arm uses this mnemonic SATCHMO. Do you guys hate mnemonics? I hate mnemonics because I write out the mnemonic and then I can't remember what the letters stand for. So I just can't figure it out. So let's just run down the list just once, just so everybody recognizes things. Sarcoid, intracellular tumor, aneurysm, teratoma or TB in the suprasellar cistern, craniopharyngioma, Rathke's cleft cyst, something in the clivus, a chordoma, hypothalamic gliomas, hamartoma of the tubercinarium, histiocytosis, what we used to call eosinophilic granuloma, meningioma, subarachnoid metastasis, optic nerve gliomas or chiasmatic gliomas, and again we have EG mentioned here and dermoid or teratoma. That's the SATCHMO mnemonic that some people use, and again I have to sit there and think about what lives in that location to be able to come up with it. Do you ever play Who's Your Daddy when you find a lesion? Every lesion arose from something. So if you think about what lives there, who's your daddy for that disease or that tumor, that's what you start with when you're making the differential diagnosis. So this is SATCHMO, died in 1971, so before a lot of you were born. And he also, if this was an ENT lecture, we'd also talk about his laryngocele. But anyway, this is another mnemonic that people use. So you can make up whatever mnemonic you want, but it's worthless if you can't remember what the letters stand for. So do it any way that you want to. Now, the most common Sella and parasellar lesions in a child are going to be hypothalamic and chiasmatic gliomas and craniopharyngiomas, and the most common Sella and parasellar lesions in an adult patient are going to be pituitary adenomas and craniopharyngioma. So those are things that we want to think about once we've ruled out the possibility of the patient having an aneurysm. So what's the anatomy of this area? So we look at the standard kind of cartoon, looking in the coronal plane at the pituitary. We start talking about things, third ventricle, sphenoid sinus. We have the nasopharynx. We have the chiasm and the second cranial nerve, the optic nerve. And again, you know, one of the things we struggled with in medical school was remembering all the cranial nerves that pass through the cavernous sinus. this is really very, very simple. We know that 2 is up here above the pituitary. All the rest of these nerves have to somehow get out of the head and get into the face and get into the orbit, and they happen to be in numerical order from top to bottom in the dural reflection along the wall of cavernous sinus. So it's 3, 4, and the first and second divisions of the trigeminal nerve. And then that leaves just one that is right adjacent to the cavernous portion of the carotid artery, the abducens nerve or the 6th nerve. So everybody should know this, and Blake did a great job of talking about this. Some people like to focus on where we're going to find a particular flavor of pituitary adenoma when it's small enough to see exactly where it started from. And people like to remember that the lactotrophs that make prolactin and the somatotrophs that make growth hormone tend to be in the lateral portions of the adenohypophysis, the anterior pituitary, and that the ACTH or the corticotroph tend to be in the midline, and that can be useful for differential diagnosis. We know the posterior pituitary has something that we call the posterior pituitary bright spot. Again, another just descriptive name. That's supposed to be neurosecretory granules that contain ADH, antidiuretic hormone, that's actually made in the hypothalamus and travels down the stalk. And that also typically enhances earlier than does the anterior pituitary or the adenohypophysis. And then, of course, we have all the nearby structures that we talked about before, the chiasm, and back here we have the mammillary bodies. The bony structures, the planum sphenoidale, the tuberculum sella, the sella turcica, the Turkish saddle holding the pituitary because it has that dural sling between the anterior and posterior clinoid processes, and the dorsum sella, and then that looks very much like what we see on imaging when we do a bone window on a CT scan, exactly the same landmarks there. And again, these drawings should be in your handout. So a couple of really basic things. Pituitary adenomas are very common. The prevalence is estimated to be almost 100 per 100,000 people. They're about 15% of tumors at autopsy, about a fifth of the tumors that are diagnosed by imaging because they're very, very common. Functional adenomas are much more frequent than non-functioning adenomas in terms of measuring symptoms for the patient, and the most common tumor is going to be a prolactinoma, one that is producing prolactin, which typically becomes symptomatic in women who are used to having a cycling of their menses. So you want to remember that prolactin-secreting tumors are the most common. Both prolactinomas and the corticotroph tumors typically present as microadenomas because the patients come in with endocrine symptomatology. It's very, very simple, but it's because they have endocrine symptomatology. So let's look at these two clinical presentations and how they're going to affect how we image the patient. Here's a patient coming in. They have an endocrine problem. A 33-year-old woman. She has menstrual cycle abnormalities, and she has galactorrhea. Relatively common presentation. How do you work up that patient? The first thing you want to find out, is that woman pregnant? Because if that woman's pregnant, we know why she has amenorrhea and galactorrhea. And you need to refer her, or someone needs to refer her to prenatal care. She's not pregnant. So now the next question is the prolactin elevated? If the prolactin is elevated, does she have visual symptoms? If she has visual symptoms, then she probably has a macroadenoma, and she can get a standard MR exam. Let me say this again really slowly so you can all shoot arrows at me for the rest of my life. If the woman has elevated prolactin and visual symptoms, you don't need to look for a microadenoma. They're going to treat her medically with a dopamine agonist. They're not going to do surgery. So you don't need to do that. You don't need to do the high-resolution thin slices dynamic scanning. This is in the literature. This is not what we do, but this is in the literature. This is how these patients should be evaluated. If they don't have visual symptoms, then you make the assumption the tumor is not big enough. Typically, the tumor has to be 16 millimeters in diameter before it extends up high enough to begin impacting on the chiasm and cause bitemporal hemianopsia. And if the patient has galactorrhea, or if you just want to take a better look, then you're going to think she has a microadenoma, and you want to do a dynamic enhanced MR. So I don't want to trash anybody's clinical practice, but if the patient has visual symptoms, then you know that they're going to have a big lesion. You don't have to be looking for a small lesion. So go back to this patient. Her pregnancy test was negative. Her serum prolactin was over 1,000. That's clearly abnormal. It should be about 28 or 35. And by the way, all the guys in the room, raise your hand. Let me just make sure that you're still awake. The normal prolactin, serum prolactin in men is almost identical to the normal serum prolactin in women. So if we ran around and measured all the male patients, all the male people, we'd find out that we have prolactin all the time. So have you guys heard of the stalk effect? Anything that presses on the stalk can cause an elevation of prolactin into the range where it will make a male or a female patient symptomatic. But typically, it never gets above 200 nanograms per milliliter. This is a clinical thing. I know that you're not here for an endocrinology lecture, but this relates directly to the imaging. And something that is really fascinating is the conventional test for prolactin is going to get confused if the prolactin is over 10,000. So if the patient is a woman who has amenorrhea and galactorrhea and has a macroadenoma and bitemporal hemianopsia, they could measure her prolactin level and get a false negative that her prolactin is not elevated unless they do a dilution study. And they're supposed to know that, but sometimes they're not that sophisticated. So this stalk effect is something that can also elevate prolactin. In addition to pregnancy, we can have a prolactinoma, and there's a whole list of drugs that also elevate prolactin. So when somebody comes in with amenorrhea or galactorrhea, or a male patient comes in with decreased libido and maybe kind of man boobs, you need to think about all the spurious things that may cause elevated prolactin. So we'll leave that and go on now. So again, when you do pituitary imaging, you want to have the best spatial resolution that you can get. You want to have the best resolution of contrast enhancement that you can get. There's a lot of debate about how valid this actually is in clinical practice, but you typically try to do very, very thin sections, and you want to do dynamic enhancement to see that typically microadenomas enhance after the normal adenohypophysis and after the normal posterior neurohypophysis. What are the gross signs that you have a pituitary adenoma? The classic ones are that you have depression of the floor of the sella and you have deviation of the pituitary stalk away from the lesion. And this is the classic way that we talk about localizing where the microadenoma is if you can't see it because of a change in signal intensity or a change in enhancement. It doesn't always work. Classic example here of doing dynamic enhancement, flow voids for the cavernous and supraclinoid carotid, optic nerves there. We're going to give contrast material, and typically the microadenoma will enhance later and less brightly than the normal anterior pituitary or adenohypophysis. And people talk about this as the flip-flop. And when you see that in the patient who has the right clinical context, then you can say that that's a microadenoma. The reason why this happens is that the normal pituitary has a rich capillary network, and the microadenoma is going to push the normal pituitary and the normal vessels out of the way, so there are fewer vessels in the neoplasm than there are in the normal pituitary. That's counterintuitive, isn't it? We normally think about neoplasms as having neovascularity, but if you look at the time density curves for MR enhancement, the blood pool is way high here and then drops off rapidly. The normal gland enhances a little bit later than the blood pool and drops off a little bit more rapidly, but the adenomas are going to enhance later and they're going to wash out later. So if you don't know the timing that you're using, you could fake yourself out about where the adenoma is. So this flip-flop between the normal gland enhancing first and the adenoma enhancing later is what we look for when we do the dynamic contrast enhanced scans. So here's a case here, classic appearance, outside scan done at Elsewhere General Hospital, and a scan that was done with better technique showed the classic appearance here, stalk deviated, floor pushed down, and a nice little small lesion. Microadenomas have to be less than 10 millimeters in diameter, so that can really help out. Now sometimes these things don't work out the way that you want to, and by the way, I kind of diminish the significance of microadenomas by saying that we can give them cabergoline or bromocriptine dopamine agonists as a way of treating them without surgery. Patients die from corticotroph tumors. They die from ACTH tumors. They die from Cushing's disease. So if the patient actually has clinical Cushing's disease, where the source of the ACTH is the pituitary, you have to work to find that lesion, or the neurosurgeon has to take out the entire pituitary and give the patient panhypopituitarism. So here's a patient that had elevated ACTH, and the initial scan showed what appeared to be the classic signs of depression of the floor and deviation of the stalk away from something that appeared to be hypoenhancing, and then a repeat scan showed exactly the opposite. This was actually the microadenoma surgically proven in this patient, not this area over here. So you have to be very careful in using your technique when you think the patient has a microadenoma and you're struggling to find it. Very, very important. So the patient that we had here was treated biochemically, and again, we have this microadenoma in this patient. Now, the other presentation for patients who have pituitary adenomas is when the tumor is big, larger than 16 millimeters in diameter, has grown out of the pituitary fossa, is coming up underneath the optic chiasm, and gives the patient the classic bitemporal hemianopsia. And this is from the London subway system, and this was at the time when the Tomb Raider game had just come out, and they had these big billboards there, but it says avoid tunnel vision. Because does the patient come in and say, I have bitemporal hemianopsia? No, the patient comes in and says, I can't see anything off to the side. I'm driving down the highway and cars are coming out of nowhere. I keep bumping into the door jamb when I walk through a door. That's what the patient says. If they come in and they say, I have bitemporal hemianopsia, it's because they're a physician or a nurse or somehow else involved in healthcare. So this is a 23-year-old man. He's required to have an annual physical because he's on active duty. So he's totally asymptomatic as far as he knows, and when they do confrontation testing with the wiggly finger, they see as bitemporal hemianopsia. So this is the scan he has. Is this normal or abnormal? This is a big honkin' pituitary adenoma. This is a really large pituitary adenoma. And large lesions are old lesions, and old lesions undergo all kinds of degeneration. The degeneration may be hemorrhage, it may be necrosis, it may be cystic degeneration with fluid accumulation. So we don't know why he was asymptomatic, except that maybe he had a strong desire to serve, and he was ignoring the symptoms that he had because he thought that they would withdraw him from the service that he wanted to do, because a lot of our active duty people, they really want to do what they're doing, and they don't want someone to say, you can't be a pilot, you can't be a Marine, you can't be a soldier, sailor, airman. But he has a classic macroadenoma. So it was resected, and I just want to talk a little bit about macroadenomas. First off, the snowman sign. How many of you have heard the snowman sign? Okay, so how many of you have heard the snowman sign? So I'll keep doing that for the rest of the afternoon. So anyway, you have this central constriction, which is classically described as being due to the remnants of the diaphragma sella, or in some cases, it's actually the circle of Willis acting as a little clamp around the tumor. So he has got that classic snowman sign, which, by the way, anything that grows into the suprasellar cistern can have that central constriction. You can also see it with craniopharyngioma. So again, he has a snowman sign here. Here's another pituitary macroadenoma. We see a little bit of the lamina dura, the floor of the sella here, but we're missing that dark line of the bone down here, but it's clearly grown up, and the chiasm and hypothalamus are draped across the top of the mass. Classic presentation for pituitary macroadenoma. Now, how many of you were told that macroadenomas are non-functional? How many of you have been told that they're non-functional? Because that's what they used to teach. They used to teach that macroadenomas are not hormonally active. And that's absolutely not true. It depends on whether the patient is reacting to the hormones that the tumor makes. We'll talk about that just a little bit more in a second. So again, we have this large lesion of pituitary fossa. It's not really hard to figure out. Blake told us all about why we get bitemporal hemianopsia. The critical thing is the lateral retinal fibers do not cross, they go straight back. And then you have to work out how the image is inverted by the lens of the eye, and you end up with bitemporal hemianopsia. So let me just tell you something about the tumors and how they present, and kind of a little historical thing. I don't believe that we have to explain passages in the Bible using modern science to accept it. I think that faith is that you don't have to have a scientific explanation. But listen to the story of David and Goliath. Goliath was a big guy. He was a giant. Why was Goliath such a big guy? Because he had a somatotroph tumor. He had a growth hormone secreting tumor. And the tumor was there from before his epiphyses fused when he was a teenager. So he ended up having gigantism, and then his epiphyses fused and he had acromegaly. But he was also an angry guy. Why was he an angry guy? Because he had increased intracranial pressure. Why did he have increased intracranial pressure? Because he had a gigantic pituitary macroadenoma. So he's a big angry guy. Little David was able to kill the giant. How did he kill him? He hit him on the side of the head with a rock. I grew up in Southeast Washington, D.C. Our favorite form of entertainment after school was throwing rocks at each other. We threw rocks at each other all the time. Nobody ever died. You'd get a scalp laceration. You'd bleed like stink. If you get the bleeding to stop, you didn't tell your parents, and you never went to the emergency room. So what happened was, and I'm going to step away from the mic just for, well, I'll try to do it here. So little David was able to sneak up on the giant because he realized the giant could only see him when he was directly in front. When he went off to the side, the giant didn't see him. Now you see me, now you don't. Now you see me, now you don't. And then when he hit him on the side of the head with a rock, he caused a hemorrhage into the pre-existing tumor and gave him pituitary apoplexy. And that's how the giant was killed, and that's why he was a giant, and that's why he was an angry giant. Isn't that a fantastic story? It's a fantastic way to remember that. Yeah. I didn't make that up. Just to let you know, I don't want to take credit for having made that up. So pituitary apoplexy is typically hemorrhage into enlargement of the pituitary, either because of an adenoma or in the case of Sheehan's postpartum necrosis, physiologic enlargement of the pituitary during pregnancy. So that's what you want to think about. So microadenomas less than 10 millimeters, macroadenomas greater than 10 millimeters. So let's talk about something else for Sella and Parasellar. Enlargement of the stalk. I was told that a radiologist with a ruler is a radiologist in trouble, but sometimes you look at an image and you say that pituitary stalk is too thick, or somebody's giving you that the patient has some kind of endocrine abnormalities. What causes enlargement of the pituitary hypothalamic stalk? A lymphocytic hypophysitis, which is an autoimmune thing that occurs at the end of pregnancy or after delivery. Langerhans histiocytosis, what we used to call EG. Metastatic germinoma from the pituitary region or primary suprasellar germinoma, lymphoma, sarcoidosis, and TB and fungal diseases that love to be in the basilar cisterns. There's a wide differential diagnosis here. Lymphocytic hypophysitis is actually relatively common if you're imaging postpartum women. It can cause pituitary insufficiency, and again, it has been associated with a loss of the posterior bright spot. So here's an example here where the stalk is a little bit too thick. I think you'll all agree that this is too thick, and there's also a little bit of heterogeneous enhancement here in the pituitary. So that's something to put in your back pocket to be able to look for that. We want to talk about Rathke's cleft cyst. So here's a patient that presented with a man that presented with headaches and no other history was provided, and has a lesion that looks like it's fluid growing out of the pituitary and into the suprasellar cistern. And theoretically, if this is a Rathke's cleft cyst, it will be localized to the pars intermedia, and that might be helpful information when we do the SAMS questions later on. When they took this out, because it was producing mass effect, they found all of this kind of colloid material there, and for the pathologist, they can only make the diagnosis of a Rathke's cleft cyst or a craniopharyngioma or a dermoid or an epidermoid when they see intact lining to be able to sort those out. But Rathke's cleft cysts are very, very common lesions. They are related to pars intermedia cysts. In fact, most of the literature says they're exactly the same thing as a pars intermedia cyst between the anterior and posterior pituitary. They're relatively frequent at autopsy. They're relatively commonly seen as incidental findings on imaging. When they're symptomatic either because of compression of the normal gland or because they're pooching up into the suprasellar cistern, causing the cistern chapel, that would be interesting, growing into the area of the chiasm and pressing on it. So here's another example of a pathologically proven Rathke's cleft cyst. One of the things that literature talks about is hyperintensity on T1, and the other thing literature talks about is having this nodule. Amit, do you use that nodule sign to diagnose Rathke's cleft cyst? where there's a little hypointense dot there. The literature talks about this. Do you guys read the literature and then realize that it has no applicability to the real world? Does that ever happen to you? Because this is one of those things where, okay, your differential is craniopharyngioma versus Rathke's cleft cyst. If the patient is symptomatic, they're going to take it out. If it's really small and completely intracellular, they're not going to take it out if a patient's asymptomatic. So that's just something to keep in mind. Another case for Sella and Parasellar. A 50-year-old woman has headaches and blurred vision for 1 month. She has papilledema, she's obese. We know that this is probably a patient who's going to have pseudotumor cerebri, perhaps due to some kind of dural sinus stenosis. But we have now CSF herniating into the pituitary fossa. And again, the enhancement of the gland and the stalk may be relatively normal for these patients. The patient also has on imaging the signs that we look for of papilledema, which is dilatation of the subarachnoid space that surrounds the optic nerves as they go in to attach to the globe. So again, here she does look a little bit obese, and she has this sheath of CSF surrounding the optic nerves. Now, the last things that I want to talk about in the time that I have, non-pituitary lesions, craniopharyngioma. When I learned about craniopharyngioma, it was when I was reading 50 to 60 skull radiographs a day as a first-year resident at Georgetown, and a significant percentage of those were going to be in kids. And they told me if you see intracranial calcifications in a kid, if they're in the pineal region, they have a germ cell tumor or a teratoma, and if it's in the suprasellar cistern, they have a craniopharyngioma. And that's what they told me to look for, so it kind of stuck a little bit. And I learned a little bit about craniopharyngiomas, and I learned that craniopharyngiomas were cystic tumors. They had this kind of wet keratin, oily material in them called machine oil. They were very commonly calcified, and the calcifications were usually peripheral. Something I learned much later is that pediatric craniopharyngiomas can stick to the adjacent brain, they can stick to the hypothalamus, they can have an astroglial reaction around the outside, and if the tissue given to the pathologist is from that astroglial reaction, the pathologist will make the wrong diagnosis and call it a hypothalamic glioma. It's a very interesting thing to remember about craniopharyngiomas. Now, the ones that we see in childhood are called adamantinomatous craniopharyngiomas. You know why they're called adamantinomatous craniopharyngiomas? They're named after that 1980s rock group, Adam and the Ants. So they're the adamantinomatous craniopharyngiomas. Now, the reason why they're called that is that they are epithelial lesions, and the epithelium that forms the lining in the craniopharyngioma looks like the enamel organ of a tooth bud. And so the pathologist gave it that name of adamantinomatous. Now, then the pathologist really jerked me around because they said, oh, by the way, there's a second kind of craniopharyngioma. And the second kind of craniopharyngioma accounts for the second age peak of craniopharyngiomas, which is in the 30s and 40s, as opposed to in the first 2 decades. It is histologically a totally different tumor. It doesn't have that adamantinomatous histology. It has a squamous histology and sometimes a papillary histology. It's not cystic, it's a solid tumor. It doesn't calcify, but it's easier to remove because it doesn't incite that reaction from the adjacent hypothalamus. So it's much easier to get it out. So there's 2 different tumors, 2 different morphologies, 2 different imaging patterns, 2 different age groups, 2 different prognosis that are both called craniopharyngioma. Why did the pathologist do that to us? They could have given it a different name. So let's take a couple examples to look at craniopharyngiomas. 23-month-old boy has headaches for 3 weeks. How do you know that a kid has headaches? My grandson is 20 months old, and you know, if he's touching parts of his body, I know they're bothering him. If he's touching his ear, he's got an earache. If he was holding his head like this, then I would think he has a headache. But they don't come up and they say, I have a headache. Just like they don't, well, actually, my grandson might say, I have diplopia, or I have a bitemporal hemianopsia, but he's not going to say the other things. So anyway, here's the CT that was done first. Classic appearance, rounded lesion, suprasellar cistern, peripheral rim of calcification. That oily, wet keratin causes T1 shortening, so the lesion can be bright on the T1 weighted image. Sometimes they are more solid and less cystic, but this one is a classic in that it's primarily a cystic lesion. The calcified rim is a little bit hypointense on the flare. The lesion is clearly extending growing both above and into the pituitary fossa. And this is something that threw me off just a little bit when I first started thinking about it. When you have a pituitary adenoma, it starts inside the sella, but we saw a couple examples where the lesion was equally suprasellar and intrasellar. That can make it a little bit difficult to play who's your daddy, where did the tumor actually start? When I learned about craniopharyngiomas, I learned that about 75% of craniopharyngiomas, which we think start as a suprasellar mass, actually grow into the pituitary fossa, 75%. So when it really is arising above the pituitary, it may grow into the pituitary fossa like it does in this patient. So that is roughly the orientation of the diaphragma sella. The only living part of this particular purely cystic craniopharyngioma is the rim, and that's why you have that rim-like contrast enhancement around the outside. So this was a pathologically proven craniopharyngioma. Here's another craniopharyngioma, mostly suprasellar, but partially intrasellar, maintaining a relatively normal diameter for the pituitary fossa. Pituitary adenomas typically cause balloon-like expansion of the sella before they grow into the suprasellar cistern. So if the pituitary fossa has a relatively normal diameter and the tumor is both above and inside the sella, you might want to guess that it grew down from above as opposed to growing out of the pituitary fossa. And again, they can have that snowman kind of appearance. Just to kind of connect the dots between plain radiography and MR, if you look at this plain radiograph, how many of you see the J-shaped sella? You guys remember that terminology? So we have this lesion here that instead of producing a balloon-like enlargement, it's produced kind of a J shape to the sella. And if we actually look at the MR in the same patient, we can see again the T1 shortening, and we can see how the lesion has probably grown down from above and into the pituitary fossa. So all of these things make sense when you try to put them together for the craniopharyngioma. So here's another craniopharyngioma. I must emphasize they can have widely variable imaging appearances depending upon the ratio of solid tissue to that oily contents. They can be very, very heterogeneous, as you see here. The solid portions almost always show contrast enhancement. A few calcifications here, but all of this is the lesion. All of that is the lesion in this patient with craniopharyngioma. This patient had a transcallosal approach. I never imagined 30 years ago that the neurosurgeons would get to the sella by starting up at the vertex and going through the corpus callosum. But because they've learned how to fenestrate the floor of the third ventricle to treat hydrocephalus, they've gotten really accustomed to using that neurosurgical endoscope to go down from the top, and that was how they resected this lesion. And this again is that histology, that adamantinomatous histology, and it's a nice chunk of calcification for this craniopharyngioma. The last thing I want to talk about is the lesions that arise in the clivus. The one that we all remember, the one that we all want to remember, is the chordoma. This has been up for 25 seconds now. Can you all see the imaging feature here that tells you that the patient has a chordoma? If you look at the clivus is my favorite bone in the body. Do you know that that's my favorite bone? It's my favorite bone in the whole body because I know I'm in the midline in the skull, but it's also because I was going to name my son Clivus. My son should have been named after my father, and my son should have been Eleftherios Demetrios Smyrniotopoulos. And my wife said, there is no way, Jose, that we're going to give him that long name. It won't fit in any computer forms or anything else. So I said, let's call him Clivus. It has a masculine sound, ethnic feel. Clivus was rejected. I said, how about Nevius Flamius Smyrniotopoulos? That was rejected. We toyed fleetingly with Gluteus Maximus Smyrniotopoulos, but my son is Jimmy. But anyway, what I want you to notice is that the clivus, the cortical margin of the clivus, is missing back here. That's all you can see on this 3D reformation. But of course, if you look at the MR scan, this is the normal cortical bone around the clivus, and this is the tumor growing out of the clivus. It's clearly not involving the pituitary fossa. The posterior pituitary bright spot is intact, and this is the classic kind of presentation for a chordoma. So a chordoma is supposed to be a tumor arising from remnants of the embryologic notochord. All All of us have notochordal remnants in the nucleus pulposus of the intervertebral disc. Those cells in the intervertebral disc get chemical signals that tell them not to replicate, so chordomas do not arise from the intervertebral disc. Those cells mind their own business until the day that you bend over and pick up something and you herniate a disc, and then the notochordal cells get pushed out to press on the dural sac. So these tumors are arising from a remnant of cells that were supposed to be resorbed and extruded from the bone. And that's a critical thing in understanding the imaging of chordoma. Chordomas are almost always associated with bone destruction. You want to teach yourself to look for the bone destruction. And 40 to 60% of solitary clival lesions are going to be this primary tumor. This is the only primary non-sarcomatous tumor of bone because the chordoma is considered to be an epithelial tumor. And something else the chordoma does, it respects the dura. So the tumor typically respects the dura, and that's that black line that we see there. That's the tumor has not yet breached the dura. So those are the things that we associate with the chordoma, that the tumor is associated with significant bone destruction, but the tumor is not infiltrating into the brain or the additional soft tissues. So we talked about the difference between microadenoma and macroadenoma. The patient's presentation basically determines whether it's a big lesion or a small lesion, or in case it's not producing any hormone, nothing stops it from getting bigger and bigger. We talked about some of the clinical syndromes. We talked about working up amenorrhea. We talked about the variable appearance of craniopharyngioma, and we just finished talking about a classic presentation for a chordoma.